10 to 15 million people in the U.S. have knee osteoarthritis. And osteoarthritis is basically damage of the ends of the bones. If you look at this model, you'll see that the ends of the bones are very smooth, and we call that cartilage, and there's meniscus on each side, and the ligaments are not properly shown here, but this is essentially a normal knee. This knee depicts the damage of the ends of the bones, and the cartilage, which is what osteoarthritis damages. Osteoarthritis is essentially the wear of the end of the bone, and it's no longer smooth, and this process of wear, and as the cartilage thins out and is destroyed, is known as osteoarthritis. And so there's severity levels from mild to moderate to severe, and it depends on how much of that cartilage is worn out. And you'll see that on an x-ray. You can't see this white and or blue material on an x-ray, but you can see the space that it should take up. And on the x-ray in our office, you would see the narrowing of the space on either side of the knee or both sides of the knee. The knee, in essence, has three compartments. There's the inner compartment. On this model, it's over on this side. We call that the medial side, the medial compartment. There's the lateral compartment, the outer side, and then there's the kneecap compartment. And a full knee replacement would replace all three compartments. And this is an example of a full knee replacement. And essentially, through a larger incision, you are removing all of the cartilage from the end of the bones, or whatever's left, from the kneecap, from the femur, which is the thigh bone, and from the tibia, which is the shin bone. And in essence, by making specialized cuts that typically pre-surgery we template and we make sure we have the appropriate size and the appropriate angle of our cuts, we will then apply, once our cuts are made, a metallic implant, typically in my practice with some cement, but you don't have to, and it's glued on. And the same thing with the shin bone. The bone is cut such that now you have raw bone, and you apply a metallic implant with a plastic covering, and then this is how the knee moves. This is a much bigger procedure. It replaces all three surfaces, and it sacrifices some ligaments, typically the ones in the middle of the knee. The ones on the outside are left alone. The benefit of a partial knee replacement is that you're essentially only partially replacing the knee. You're replacing either the inner half, which is the medial side, which is shown in this model, or you can replace the outer half, or you can replace just the kneecap, or you can replace two compartments, typically the inner half and the kneecap. Again, the benefit here is you're not sacrificing potentially some normal tissue. Many patients, I would say probably 20 to 30% of patients that I see with knee arthritis, are reasonable candidates for a partial replacement. And the reason is that when you look at their x-rays, you'll see that they only have arthritis essentially in one half of the knee, either the inner half, the outer half, or sometimes just behind the kneecap. And so it would beg the question, why would you want to sacrifice other parts of the knee if they're doing just fine? Many of these patients that I see are in their 40s and 50s and 60s, and they don't want a full knee replacement. They want a partial replacement that will allow them a quicker recovery, will allow them to have a smaller, minimally invasive incision, and will allow them to feel more normal, since you're not removing their ligaments, and most of the time 2/3 of their knee is their own knee. So a partial knee replacement really allows us to treat patients specifically for the arthritis that they have, and not to remove normal tissue, which quite frankly, for, as I said, 20 to 30% of my patients, they don't need a full replacement. So this is a very appealing procedure, which is minimally invasive, same-day surgery. Typically, patients go home the same day, and great for pain relief, and very successful.